Good evening, ladies and gentlemen. Welcome to another episode of Ask Paul Anything COVID edition. Before we start grilling the professor, I would like to direct your attention to the new SDP 8-point plans to deal with the pandemic. You can find the details in the SDP website as well as a Facebook page. I believe some of the points will also be covered by Dr. Paul in the Q&A later on. An overview of the topics today includes the virus, vaccine booster treatment,
living with the virus, learning points, the SDP 8-point plan. Without further ado, let's get into APA proper.
Hi, good evening. And that's Wayin.
By the way.
SDP candidate for Marsiling UT in GE 2020.
Hi, good evening. Okay, so the first topic of the day is the virus, and there's this question from Michael Fang. What is the rate of mutation of the COVID-19 virus? More importantly, can we and are we able to outrun it with experimental vaccine?
Okay, the good news is the COVID virus actually has a relatively low mutation rate. It's much lower than the mutation rate for HIV or influenza. And part of the reason is, even though it's an RNA virus, it has a checking mechanism in place so that it doesn't make so many mistakes when it copies itself. And that's how other viruses get mutations so quickly. So I'm pretty confident that we will be able to outrun it. Okay.
So are we redoing the
Samula,
entire
start from
thing?
beginning. Okay. What was the problem? The YouTube is still running or paused? No picture, no sound.
Good evening, ladies and gentlemen. I'm Wayin, and here with
Here with
us
us
is
is SDP Chairman Dr. Paul. I'm sorry for the technical difficulty faced earlier. Welcome to another episode of Ask Paul Anything COVID edition. Before we start grilling the prof, I would like to direct your attention to the new SDP 8-point plans living with the pandemic. So, you can find the details of the new plans on SDP website as well as a Facebook page. Now, I believe some of the points will also be referred to in this Q&A in this session. So, an overview of the topics today includes the virus, vaccine
booster treatment, living with the virus, learning point, SDP 8-point plan. So without further ado, let's go into the APA proper. So there's this question from Michael Fang, and he asks, what is the rate of mutation of the COVID-19 virus? And more importantly, are we able to outrun it with experimental vaccine?
Well, the good news is the rate of mutation of the COVID-19 virus is actually slower than for influenza or for HIV. So in fact, we've had 20 years trying to come up with the HIV vaccine and failed because the mutation rate is just too fast. And even with influenza, we have to vaccinate every year. But for COVID-19, the rate of mutation is much slower. In fact, the Delta variant, it appeared even before the vaccines were rolled out. And it's the dominant variant all over the world. So I think there's a good chance we will be able to outrun it with the vaccines.
Okay, thank you. The next question from Clarence Paul Lim. What is the suitable mortality benchmark for Singapore to adopt to live with the COVID virus? For example, is it reasonable to compare it with the annual flu mortality?
Yeah, to me, the ideal mortality benchmark is 0. We don't want to have any deaths at all from what is potentially preventable. And ideally, if everybody is vaccinated, the vaccine is not 100%, but at least 90 to 95% of people will be prevented from dying from COVID. So that's number one. Number two, though, is that we have to balance between trying to track down every single case and the cost that will have an impact, not just economic, but also on other conditions. Because you can imagine when we are using, like right now, 1,200 beds in the hospital for patients with COVID, when we have a total bed complement according to the MOH website of about 9,800. So that's effectively about 11% of all the total beds. So people's elective surgeries are being delayed, people are not getting their knee replacements, and that runs the risk of them falling or having other injuries and just bad effects on their health. So ideally, mortality rate should be as low as possible, but you don't want to go to the extent of having a negative effect on other diseases.
So the next question from Max Tan. He wonders which strain is more contagious, the COVID-19 virus or the annual flu bug?
Well, the annual flu bug is pretty contagious. If someone in the office gets the flu, it's a matter of time before everybody else gets sick, unless the guy is responsible and goes home. When you start sniffing in the office, everybody else will start coughing as well. But it's similar for the COVID-19, but the difference is there are these so-called super spreading events that occur with COVID-19. And these have occurred like in the choir in Seattle, in Washington State, or in the KTVs, or in the fishery port, and most recently in the Pasir Panjang wholesale market. And the frustrating thing is after almost 2 years of the pandemic, we don't know what makes a super spreading event. And that's the subject of a lot of research.
Okay. Elvin Leong commented, personally he feels that people are needlessly panicking at this point with the rising cases, as most of the cases are mild or asymptomatic. And they have not seen, or rather he have not seen a huge jump in ICU cases yet. But from what I understand, the ICU cases have doubled since 2 weeks ago. I mean, what's your view on this?
Yeah, he's partially right. The reality is that even among the unvaccinated, more than 90% of cases have very mild disease. So there is no reason to panic unnecessarily. But at the same time, there are certain groups who are vulnerable. Those who are elderly, those with underlying medical conditions. And it is true, the number of ICU cases has doubled. And unfortunately, there's a lag period between the time of diagnosis and the time in which they deteriorate and end up in ICU. So it's very likely that next week we'll see a further rise in the number of ICU cases. And if the number of cases overall keeps rising, the number of ICU cases will also rise in tandem.
His question continues. Many Singaporeans seem to want to draw comparison with Hong Kong and Taiwan, but he doesn't think that a zero COVID strategy is sustainable in the long run. Sooner or later, they will have to open up and they will also see the huge wave as we have seen. I mean, what do you think of the approach by the Scandinavian countries and Switzerland? Do you think they could be applied to Singapore?
Yeah, this is a really interesting question. I personally think that Hong Kong and China should abandon the zero COVID strategy because they are currently, Hong Kong, China, New Zealand are probably the only places which really still have a zero COVID strategy, trying to track down every single case. and the rest of the world is coming to terms with living with the virus because the impact is so great. Now, in Hong Kong and Taiwan, the number of cases is relatively small, so they are able to lock down effectively. But once the number of cases goes beyond a certain level, it's just not practical to do that because you cannot lock down completely. You know, short of doing what they did in Wuhan in February of 2020, where the whole city went dead. You know, I mean that would be extremely destructive. And again, not just to economics, but to other health issues, mental health, and so many other things. So I don't think that the zero COVID strategy is going to work. There's an intriguing theory that's going around in some of the medical circles, and they're wondering why Hong Kong and China have got relatively low numbers of COVID cases. And one theory is that, you know, they had SARS in 2003, and there was a lot of SARS in Hong Kong and China. And there is some data that SARS protects you from COVID. In fact, I've written to friends in Hong Kong and even in Canada, and so far I have not heard of a single case of a person who recovered from SARS who has COVID. So that's an intriguing theory. We don't know for sure, but you know, if that is the case, then we cannot use Hong Kong and China as a model or as an example.
So how about the approach by the Scandinavian country and Switzerland?
Yeah, so Scandinavia and Switzerland have currently got lower rates than Singapore. You know, I think though that is a little bit artificial because it's still relatively hot over there, and they get their respiratory virus peaks during the winter time. So, you know, what they have done is they have had a low-level transmission. They have relatively high vaccination rates, not as high as ours though. And I think they're hoping that there will be sort of like almost like a herd immunity situation by the time the winter comes in.
Okay. So, is there any question from the live with regards to the virus? Okay, I think in that case, we will move on to the next topic, which is vaccine, booster, and treatment. B. Lei Kwa has this question. Will Sinovac and Sinopharm be included in our national vaccination, and do you think we should do that?
Yeah, I mean, I think ideally we should have all the WHO approved vaccines. But you know, Singapore's regulators are very, very strict. In fact, that's why Singapore's regulators are the role model for the region. If Singapore approves something, then the other ASEAN countries are likely to take that as a gold standard in a way for the region. And so, you know, I think I've told this story before. I did one job for HSA and I agreed to do it. And then they sent me, you know, this whole stack of files. I had to read through all the documentation. So my understanding is Sinovac has started the process, but Sinopharm has not. And I think HSA is going to expect them to submit all the documents before they can be cleared in the regulation. And I sincerely hope they will. You know, there's obviously a demand for it. So surely some Singapore company can help them to get through the regulatory process.
Okay. So Shanti Siva asks, what are the side effects of this vaccination going to cause in our body along, you know, when vaccinated?
Yeah, so far, you know, HSA does track the side effects, and the side effects are there. A lot of people get fever, they get muscle aches. I had very bad pain in my arm after the first dose of mRNA vaccine, and the second dose, it lasted almost twice as long. Those are relatively minor side effects. The side effect that people are most worried about is myocarditis or heart inflammation, and that occurs in about 1 in 100,000, 90,000 to 100,000 young men predominantly. And that's the reason why they've given the recommendation that for 1 or 2 weeks after the vaccination, you shouldn't do any strenuous activities. Even the SAF has done that, which is hard to imagine.
2 weeks, I think.
2 weeks, yeah, SAF, which is pretty impressive. So, but you know, if you look at it this way, 1 in 100,000 means that 99,999 people are not going to get the side effect. But when I tell that to my patients, they always say, what if I'm that one? If you're the one, it's 100%. See, and unfortunately, we cannot predict. We know that younger men at higher risk of this myocarditis, and with other vaccines like the AstraZeneca, younger women are more at risk of blood clots. But overall, the risk of side effects is relatively low. So I think it's something that you know, we should do because the benefit is quite significant.
Okay. Also from Shanti, she's asking how come those got vaccinated are still dying of COVID-19? How effective is this vaccination And how long does it last from the day you are vaccinated?
Yeah, so the vaccine is not 100% effective. I've always felt that this vaccine is version 1.0. Like for example, the measles, the MMR vaccine, that's a vaccine that's been in place for 20 years and it's super effective. The number of people with children with measles who die after the MMR is really, really low. And those are children who have very severe immune defects and things like that. So I think we're getting there. As far as we know, in terms of prevention of death, it's about 90 to 95% effective. But what that means is if you've got 100 old people who are infected, you will still get 5 of them who will die from the virus. So it's not, unfortunately, a fountain of youth. And it does reduce the risk, but it doesn't reduce it to zero.
And also that...
How long?
Yeah.
I forgot that. So the data from Israel suggests that after about 6 months, the effectiveness of the Pfizer vaccine drops off. Moderna tends to last a little bit longer, but that's just one study and it hasn't been confirmed.
And now that the government is pushing for, or rather recommending people to go for their booster shots, do you think that this is actually a correct thing to do for the elderly people especially?
Well, this is very controversial, and I think some of you are aware that the US FDA disagreed with the White House on this, because the White House was saying everybody must go and get a booster shot, and they did this because of the 6-month drop-off on the protection rates. But the FDA pointed out that the benefits are not yet proven, and as far as we know, the people who benefit the most are the immunocompromised. So those who have transplants, those who have diabetes, who are on steroids, because we know that these people don't respond well to vaccine. So they probably do need a 3rd shot, regardless of their age. And then older people tend not to respond that well to vaccines. So the FDA has suggested over 65, together with those who are immunocompromised. But they said you can offer it to those who are younger than that age. And I think that's what the government has done here. And it's moderated by the issue of maintaining the functioning of the healthcare system. Because even if the vaccine is not 100%, if it's 95, 90%, that's pretty good. And what they're thinking is that if the booster, say it drops off to 80%, and again I'm picking this figure out of the air because the Israeli figure is somewhere around 70 something to 80 something, but let's say 80%. If you can bring that up to 90%, that's 10%. So it's quite a significant number.
So it's worthwhile to do this?
So that's their argument. In view of the fact that we don't want to strain the healthcare system, it's worthwhile to do it.
Okay. So Patrick has this question. He says that he's, I think it's similar to the previous. He's 68 years old and he has received the invitation from MOH to go for his booster jab. Another person is Man Yaya. He's 60 years old, similarly invited to go for the booster jab.
Yeah, so my take on this is if you did okay with the first 2 doses, your chances of doing okay with the 3rd are pretty good. If you had a problem with the 2nd dose, then it's better for you to go and see your doctor and find out whether you should try an alternative. Like right now there are people who couldn't tolerate the Pfizer or Moderna, and then they're going for Sinovac for their booster jab.
Yeah, there's actually one question on it later on. We'll touch on that. Okay, so Peter has this question. Why after the 2nd dose, people are still affected? Seniors after 3rd dose, is there higher possibility of death or mortality? I mean, there is side effect.
Right.
Does getting more doses equate to having more chances of getting this side effect?
Yeah, that's actually a very good question. And one of the things to think about is it's a mathematical thing. See, if the risk of side effects is 1 in 100,000 for each dose, then the risk of side effects for 3 doses is 1 in 100,000 times 1 in 100,000 times 1 in 100,000. So it actually it goes up, but it goes up very marginally. It is still a relatively low risk of side effects. But again, like I said, if you are that one, it's 100%. Yeah. So it is true, and that's part of the reason why the FDA was a little bit cautious. And they said it should be reserved for those for whom the benefit is greater than the risk. But again, that's in a setting where, right now the systems in most parts of the US are still okay. Here we are a very small country with relatively limited ICU resources. So like I said, I understand the rationale behind the 3rd dose.
Okay. Teo Pui Chai have this question. There are many reports out there. Some say even third or four or more mRNA booster jabs won't stop or delay the contagion. And some say there's no need for booster. So, can you share something about this?
Yeah, so some people think that it's going to be like the flu vaccine. But like I said, the biology does not suggest that that's going to happen. And what I think is it's going to be more like the hepatitis vaccine. See, hepatitis vaccine you give at 0, 1, and 6 months. Now, we know that some people are in a hurry, say they're traveling somewhere. So they ask for an accelerated regime, 0, 1, and 2 months for the hepatitis vaccine. And we also know it doesn't work as well as the 0, 1, and 6 months. So in fact, what you're doing with this booster, eventually when all the dust is settled, we may discover that for this vaccine, you need the 0, 1, and 6 month kind of regime, similar to hepatitis B.
So the point is that there are still many unknowns, but
true.
the benefit outweighs the
for the
risk
vast majority
consideration
of
for
people,
now.
correct. Unless they have some medical reason. And like I said, it's best to get your doctor to clarify that for you.
Okay, Max Tan has this question. Is it safe to take the annual flu jab after taking the COVID-19 vaccine?
Yes, it is. At the beginning, we told people not to take the vaccines together. And part of the reason was because the COVID vaccine was new. So if you got a side effect, we wanted to make sure it was due to the COVID vaccine and not due to the flu vaccine. But now, there's 7 million doses of COVID vaccine or more, which have already been given out in Singapore. So we know a little bit more, and we are telling people, if you want to, you can take them both on the same day, or you can, separate them for a period of time.
Okay. So Rachel Chan has this question. She wanted to take Sinovac, but reports show that it is not suitable for people with vertigo.
Yeah, vertigo is actually a very common symptom. Sometimes when I go up to these tall buildings in those days when I used to go traveling, I get a little bit of vertigo. So it's the whole spectrum. If it's just a mild vertigo, it should be all right. But if there's some underlying neurological disease, then best to talk to your doctor.
From Meow, is there the possibility of the COVID virus becoming more resistant to the vaccine as a result of more and more people being vaccinated, or rather more and more vaccinated people being infected?
Actually, it's the other way around. Because if a vaccinated person is infected, then there's no with the same virus, there's no advantage to the virus to avoid the vaccine. See? So what it is this is a theoretical risk that you have what we call vaccine escape mutants, where when you have vaccinated the whole population, and then every now and again the virus mutates to try and break through the vaccine sort of ring around it, and that has actually been well documented for hepatitis B, because there are certain individuals with very high load of hepatitis B. Now, hepatitis B is a chronic infection. Okay, people have hepatitis B for a very long time, so it's different from this virus, which is an acute infection. You're sick for a while, and then even if you get the so-called long COVID, that's usually the virus is gone, and it's your immune system overreacting to it. So I think the chances of the virus becoming more resistant is relatively low, but I wouldn't say never.
Hong said that she had completed, or he have completed the second jab end of May, and now they have booster jab. If need to, can he or she ignore the booster jab but change to Sinovac or Sinopharm all over again after a year?
Yes, you can, because currently under the regulations, the vaccinated status is based only on 2 jabs. They have not changed it to 3 jabs, and people are being invited to take a 3rd jab. If you want to take a 3rd jab from a different kind of vaccine, Sinovac or Sinopharm, that's perfectly fine. In fact, there's a trial going on at NCID where there are people who had allergic reactions to the mRNA vaccine, and they are actually being invited to get the Sinovac vaccine, and then they are monitoring them very closely. They're checking their immune response and how they respond to the virus. So no issue.
Is there like a time period that you have to wait before you get the other vaccine?
No, at the moment, no. In the US, they've gone back and forth. So first it was 8 months, then 5 months, and now I think they've settled on 6 months. So it's a completely new disease and new vaccines as well. So we are learning as we go along.
Okay. So Sarah has this question. She mentioned that her wife received the first COVID jab and is having rashes, all over his body. Went to see a GP and dermatologist, but it's not helping. So, what is the? Okay, he is also the sole breadwinner, so he thinks that going to A&E is not a good idea. What's your advice to them?
Yeah, frankly, if anyone has a complicated skin condition, I always recommend the National Skin Center. And you can get a referral from the polyclinic, and they will get you an appointment with the National Skin Center. If you can afford it, you get a GP to get you a referral, but they have all the expertise there. And it's very hard to describe an actual clinical situation. It's best to leave it to the experts, and they've been very good. I take my mom there.
Okay, the last question here. Kelvin is concerned about her 9-year-old daughter who may be getting the jab next year. So we are now going into the jabs for the kids,
children, right?
Yeah, the children. So do you think it's necessary? Do you think it's safe? And what are the risks involved?
Yeah, right now there's no country in the world, with the exception of China with Sinovac, which is vaccinating 9-year-olds. And the reason is that they want to make sure that the vaccine is safe before they actually license it. There's a lot of talk of the US licensing it, but they've actually looked at the dosages. And in fact, there's a good chance they may license a lower dose than the same dose that's used in adults. Because children are not exactly small adults. They have different physiology, their immune system is different as well. So right now it's not recommended anywhere. But she's quite correct, or he is quite correct, that it is likely to be recommended, but I don't think it will be recommended without good safety evaluation and careful monitoring.
Without significant research.
Yeah, correct.
Yeah. Okay. So, Teo Pui Chai asks, will there, in the future, will there be an effective treatment for COVID infection, just like antibiotic to infection?
Yeah, I sincerely hope so. But the reality is that most viral infections have got no good antivirals for acute viral infections. For chronic viral infections like Hep B, Hep C, and HIV, there are really good drugs out there. But even for the flu, Tamiflu, which is the most widely taken drug, all it does is it reduces the symptoms of illness by 1 day. So instead of getting sick for 5 days, you get sick for 4 days. See, so it's not a hugely dramatically effective drug. So there are a lot of drugs that are now entering clinical trials, but I think it remains to be seen.
Okay. So is there any question from our live page? Okay. We are loading the question and we will get back to it shortly. So now the next topic, living with COVID. Liao Kian Tat has this question. With this sudden surge, do you think that the government should lock down the city rather than playing with the numbers of packs, social gathering, workplace default models? What are your thoughts?
Yeah, the reality is though, it's too late to lock down. Lockdowns only work, as I mentioned, in like the one in Wuhan in February 2020, when they're super drastic and when there's the ability to control the virus. Right now, the virus is everywhere. See, there's lots of household transmission, there's transmission in childcare centers, there's transmission in nursing homes, there's transmission in workplaces. And so it's very, very difficult to, and a lot of these are essential, like a nursing home. How are you going to keep people away from a nursing home? So it's just not possible to do that. So a lot of people are asking whether we should have another circuit breaker. And frankly, I think another circuit breaker is going to do more harm than good.
Okay. As you mentioned that the time for the virus to hit the peak is probably about 1 week after getting the virus. So are we looking at the peak numbers? When are we looking at, in terms of timeline, at the peak number with the current measures in place?
Yeah, so there are two different peaks that we're talking about here. So the first peak is the peak number. And what you've heard from the Ministerial Task Force is that the anticipation is the peak is going to happen next week. See? So we are not yet at the peak, unfortunately. And the prediction based on one of the mathematical models is that the peak will be about 3,200 a day. And that's going to be in the next week. You may have also heard the number of 5,000, and that's kind of alarming because if it's 5,000 and you've got 2% of them who are sick and need hospitalization, that's still a significant number. See? So those are numbers which are troubling. But the number which is really troubling is the 7 days after the onset of illness. That's for the individual patient. So what that means is they are going to turn sick 7 to 10 days after the original illness. And so the ICU peak actually lags behind the incidence peak by about a week. So if we see 3,200 new cases, say the middle of next week, then what that means is that the peak ICU will occur 2 weeks from now. So it's a little bit complicated to think about, but I think unfortunately, and this is why I understand these new measures, the time frame I understand, the actual measures themselves are really perplexing.
Okay, so let's go into the next section where we talk about living with COVID. So Liao Kiet Tat have this question with the, Liu Huai Wen have this question. Any thoughts on the trajectory of the stabilization phase? Do we see people with less resources having a poorer prognosis in this new wave?
Unfortunately, yes. And this is something which has been seen all over the world, that the virus disproportionately affects the marginalized. We saw that last year with the migrant workers. And part of the reason is, when the default mode of treatment is home treatment, then homes are very different in Singapore. You've got the huge good class bungalows where you've got 3 or 4 people living there, and then you've got these tiny rental flats where you've got 6 or 7 people living in one confined space. So that unfortunately is going to lead to increased within household transmission in the small cramped quarters where you've got large families living there. And if you've got seniors living there, there's a risk that they may not be able to get medical attention, which is why one of the key points in the SDP 8-point plan is to ensure that medical attention goes to those who need it, rather than just following some protocol and keeping people in hospital just to monitor them. But ideally, the healthcare resources should be reserved for those who are actually unwell.
Tan Sui Heng have this question with regards to living with COVID. What are your views on Jamus Lim's view with unmasking outdoors?
Yeah, Jamus' views are interesting, and I think he may be right, because as you know, with outdoor, there's a lot of cross ventilation. So the risk of a particle staying in the air for a long time is relatively low. There's also UV light. In Singapore, we get plenty of UV light, which is actually a very effective disinfectant. But currently, the data are contradictory. So I think it'd be worth trying out. Maybe they could do a pilot. Like they allow cycling on sidewalks in certain towns, and then it became a national thing. So it's always a possibility.
Liu Huai Wen asks, as we are busy dealing with the endemic, do you see a neglect on other communicable diseases? Have the face mask lived up to its name and played a key role in limiting other respiratory illnesses? Do you see us going back to not wearing a mask?
I sincerely hope that we do, okay? Because I don't like wearing masks, and I have to kind of force myself to wear the mask when I need to. But there's some very interesting data, and we just got a study accepted for the Journal of Clinical Virology. It will come out in the next couple of weeks. And what we saw was actually the measures that were put in to control COVID, they reduced the incidence of influenza, but they had no impact at all on RSV, which is respiratory syncytial virus, and the rhinovirus, or the common cold. So there's something kind of unusual about how these viruses spread, and basically, it gives us in the field a lot of humility, because there's a lot that we have to learn about these things.
Okay. So Teo Pui Chai asks, given the sudden surge in COVID-19 related death at about 28 in 2 months, last month and this month, as compared to 37 deaths in the 16 months prior, is it ignorance or complacence of the vaccinated people who has caused this spread?
Yeah, I don't think it's really fair to blame the people for the spread of the virus. To be honest, in December, when I saw the results on Pfizer and Moderna with the 95% efficacy, I actually was contacted by a couple of other companies who wanted to do studies on vaccine. And I told them, don't waste your time. It's game over. You might as well go and buy shares in Pfizer and Moderna. And I was wrong, because as we found out, the 95% was for the first 2 months after the dose, and the efficacy drops off after about 6 months. So it's not really, if even medical professionals had a lot of overconfidence in a way in the vaccines, you can't really blame the people for that. And there's also a paradox. You see, the vaccines, like I said, they're highly effective at preventing severe disease. They don't prevent infection, and they have a very limited effect in preventing transmission. So the paradox is, if you get infected and you've been vaccinated, you may not get so sick. So you may end up going out and going to the market or something like that, and you end up spreading it to somebody else. Whereas if you were not vaccinated and you got sick, you'd stay at home, and you would go to see the doctor. So you would go out of circulation. So this is a paradox which has been seen with some of the other vaccines. When they do not completely prevent infection itself, you paradoxically, because they prevent severe disease, they end up spreading the virus even more. And that's very hard to deal with.
So in view of this, the 3,200 and 5,000 number that is highlighted, is there actually a chance for us to really live with the virus?
Well, I think we've got no choice. The 3,200, like I said, is a conservative estimate. If we're talking about 5,000 every day, frankly, even if we tried the Wuhan February 2020 style lockdown, I don't think we would be able to prevent that, because there's transmission within households. There's, we've had HDB blocks where you've had transmission within the stack itself. So we've got no choice. We have to live with the virus. And because we have to live with the virus, we need to concentrate on protecting the vulnerable, those who are immunocompromised, and not straining the healthcare resources.
Okay. The next question from Serena. With the prevalence of COVID infection, frontline and healthcare workers risk infection not just from workplace, but also from home and the community. In such event, who is going to fill these roles when infected workers need to be quarantined? Example she quoted is the bus driver at the interchange clusters.
Yeah, the time for quarantine has actually been reduced significantly for vaccinated healthcare workers, and also I understand for vaccinated bus drivers, and I think that makes sense. Frankly, as we move towards 3,000, 4,000 cases a day, the place of quarantine is going to get less and less, because if you're exposed to the virus all the time, then the key has got to be preventing you from getting severely ill, rather than, you can't live in a bubble. You see, nobody can live in a bubble for that long. And if people around you, left, right, and center, are getting infected, it doesn't make sense. In a way, you should maybe quarantine those who are infected, something like that. So it's too tricky to do. And I think within a healthcare setting, it's particularly tricky because you want to make sure that you don't have healthcare workers infecting vulnerable patients. So there are ways and means of doing that. We do that sometimes for people who've been, I had a physiotherapist whose daughter had chickenpox. And I insisted that from day 10 to day 21, after the exposure to her daughter, that she be put in a desk job. Because she's a physiotherapist, she goes around the hospital, she could have spread the chickenpox to anyone. And it's quite funny, because by day 20, she was still fine. Then finally, day 21, the spots popped out. And I said, okay, thank goodness. At least I was right on that. But that's the dilemma in healthcare settings, because you've got to protect the vulnerable, but at the same time, you don't want to strain the resources. And so the healthcare workers in Singapore are well equipped with PPE. So hopefully the chances of them getting infection is relatively low.
Okay. Francis Ang asked, as an infectious specialist, do you think we should go the Western way of living with virus or the Hong Kong zero virus policy? A little bit of a repeat of the previous question.
And I think, it's not, there's this terrible sort of binary approach that we take here, Western and Eastern, and it's not true, you see. I mean, Japan and Korea are living with the virus. Japan had the Olympic Games, and it was quite sad that there were no spectators, but, they had people coming in from all over the world, and it was done in a relatively, we didn't have huge numbers popping out. They had huge numbers during the games, but not, a spike after the games. So I think, like I said, apart from Hong Kong, China, maybe New Zealand, the whole of the rest of the world has gone to living with the virus.
Okay. Jerome Tan have this comment, And so recently he's tested positive for COVID-19 without any symptoms. Okay, and he was being transferred to a CCF, a care center facility at Village Hotel Sentosa, where he was assigned to a room with another symptomatic patient. His concern is that what if he is actually a false positive, but being placed together with a symptomatic positive case, is it a really bad idea for that to happen? And he add on that later on his roommate was actually transferred to a hospital because his symptom got worse and not recovered. And thereafter, he became symptomatic.
Yeah, you know, I don't think you can blame his roommate because, as I mentioned, you see, the pattern of the disease is it starts with very mild symptoms. And then day 3 or 4, you start losing your sense of smell. At first, you just get a bit tired, you get a bit of running nose, you lose your sense of smell. And if you are in that percentage, the about 1 or 2% who's going to get severe disease or pneumonia, that only happens on day 7, 8, 9, 10. See? So it's quite possible he was going to get sick anyway. See? So he can't blame his roommate. There is this concern about false positives. There's a relatively low rate. And I know last year we had a couple of cases. There was a student who was a false positive and it created a whole panic. But you know, now we have ART. You can test yourself. And I think if you test yourself and you're repeatedly negative on the ART and somebody tells you you're positive, then you can go and ask them, you know, can you repeat the test? Because false positive rates are relatively low with PCR. There are some false positives with ART in a low risk population. But like I said, you can use a different brand. There are like 3 or 4 different brands which are out there. So I think this should not be a major issue.
So there is no concern whatsoever sharing a room with
Yeah, you know, the concern is if you are asymptomatic and the guy is coughing away, you can't sleep. You know, but I can tell you it's better to be 2 persons per room. And this is what I tell my patients. You got 2 persons per room. It's better than 6 people in a room in a cohort ward in one of the public hospitals.
Okay. So any questions do we have for living with the virus? A couple of questions. Let me see. Is it true, from Wong Po Chun, is it true it is not possible to have a herd immunity just by vaccinating the population?
And the answer is unfortunately yes, with the current vaccines, because they don't prevent transmission. So herd immunity, Singapore has achieved herd immunity for measles with about 97% of the population vaccinated. There's still about 2 or 3% who are not vaccinated. And these are people with medical reasons, or there's a small number of individuals who refuse to take the MMR. They cannot go to primary 1. They have to they have to homeschool their kids, you know. But that's enough. So 97% is what you need for measles to prevent. That's because the vaccine prevents transmission. Now, unfortunately, with the COVID-19 vaccines, the vaccines don't prevent transmission. So even theoretically, even if you get 100%, you could still get transmission going on. But with 100%, you're not going to get severe disease.
Okay. Zen Weaver asks, can clarify if one who is vaccinated and infected has a less likelihood of infecting others due to the viral load being lesser? Or is it the same viral load with vaccinated versus non-vaccinated? Yeah,
so this, actually I know the answer to that. And the reason why I know the answer is there's a study published by the NCID. And what they found was in the first 5 days, the vaccinated and unvaccinated had the same viral load. But after day 5, for the unvaccinated, the viral load slowly starts to taper down, whereas for the vaccinated, it comes down very quickly. So it takes a while for the vaccine to kick in, the immunity driven by the vaccine to kick in. But after day 5, it comes down.
Okay. There are a couple of questions here which I think is quite interesting. Apple Joy Tan asked, do you think it is safe for preschooler to go to school now with the rising number of cases?
Yeah, and I think it is, and I'll tell you why. You know, a few years ago, when they had hand, foot and mouth outbreaks, they used to close the childcare. Because they didn't want it spreading within the childcare. There was a threshold. I think 3 cases, there was a warning, and 10 cases, the childcare got closed. The trouble is, my colleagues at the School of Public Health, they studied this, and they found if you close the childcare, where's the kid going to go? The kid's going to go to the playground, you know, and they're going to mix with other kids. So you end up actually having more virus being spread by closing the childcare. You can't keep the kid at home all the time, see, because the kid needs to run around. It's for the mental health and well-being of the kid. So frankly, I think unless the play school is actually closed, you should go.
So how does the COVID virus actually affect children versus adult? I mean, there is very little cases of children getting the virus compared to the adults.
That is true, and this is something that's been seen worldwide. You know, in Singapore, as you heard, there are more than 400 kids who have been infected, but not one of them has needed oxygen, and not one of them has needed any treatment so far, touch wood. But this is a question that many people have looked at. In fact, I've worked with some of our pediatricians, and we're trying to answer that question as to why children don't get severe disease. There's a few theories. One is that the ACE receptor may not be mature enough in the child. So it's the older children or the young adults before they have enough ACE receptor for the virus. Another theory is, you know, children get colds all the time. So maybe the common cold gives them some kind of cross protection. But a lot of this is still speculation.
Kumarasan asked, what is the current research around Ivermectin for treating COVID? He also notes that the SDP plan did indicate an experiment group to scientifically prove and disprove its efficacy.
Yeah, so we studied ivermectin in the dorms last year. Ivermectin, theoretically, it's got animal data, it's got some experimental data, and what we did was we used it for prevention. And we did see a modest benefit, even though we only used a single dose of ivermectin. And part of the reason why we did that is we did the study including hydroxychloroquine. And at that time, the authorities worldwide were very concerned about the safety of hydroxychloroquine. So we only used the licensed dose of ivermectin, which is a single dose. So that's the reason why I think it's worth studying. There have been studies looking at ivermectin in treatment, and it doesn't seem to work. So we studied it in prevention. Now, a lot of the antiviral agents, you have to start them really early. You have to start them day -1, day 0, and day 1. You know, and that's the reason why a prevention drug, we thought it might work in prevention. And that's why we think it's important to do a study. You know, a proper study so you can either prove or disprove whether it works.
Patrick Kwok have this question. Why is Taiwan having low daily cases when their vaccination rate is so low, and they are also struggling to get vaccine, but yet they can achieve such single-digit numbers?
Yeah, Taiwan has a very sophisticated public health system. I know some of the people involved, and they, in a way, they're forced to, because Taiwan is not part of the WHO. See, so they're forced to come up with their own strategies, their own approaches. They also have a national health insurance system. So every GP, every public hospital, every private hospital is linked to this national health insurance system. So they find contact tracing really easy. You know, they can track the number of people who have fever, the number of people who go and see the doctor for a cold, and then they can swoop in and they can do an investigation. And that's the value of a unified national universal healthcare system. So I think that is a major reason why they've been able to function. The other reason, of course, is they've been lucky, I think.
Okay. Aksha have this question. What about the Novavex vaccine?
Yeah, I have a great deal of hope in the Novavex vaccine because in the clinical trials it seemed to do really well. The thing is, FDA still hasn't approved Novavex, and neither has EMEA. In fact, I think Novavex is going to Brazil and India to try and get approval because it's actually a protein vaccine, and it's a more conventional vaccine. It's made similar to the hepatitis B vaccine. So it's a recombinant protein, does not involve mRNA, or and it doesn't even involve a virus. So it's not even a kill virus like Sinovac or Sinopharm. But you know, they said it will be out by the end of the year. And in fact, Singapore has an advanced purchase. Will be once it comes out, Singapore will be one of the first countries to get it.
Okay. So Kwama has this question: is the Pfizer vaccine designed for Caucasian bodies and you know, their environment? Is it suitable for us as well? Does it work the same way?
Yeah, so that's a very good question, and that question came up because, you know, in the clinical trials in the US, they mandate that you have to have a certain number of African Americans, a certain number of Hispanic Americans, but the number of Asian Americans in the trials was only about 5 to 7%. But the Pfizer vaccine has been studied in Singapore specifically to address that question, and the antibody levels are pretty good. And as far as we know, in terms of the effectiveness on severe disease, it's at least as good in Singapore as it is in the US.
Okay. So now let's move on to the learning points with this. I think the same question that George has as regards to the Taiwan, so we'll skip that. Titus Lim has an opinion that the COVID-19 pandemic response has been poorly managed and is now out of control. No one in the hospital, not one of the hospital is clean for A&E emergency attention, as every A&E department is handling COVID-19. I mean, based on your recommendation, how should we manage this better, and how can we manage this better with living with COVID?
Okay, I think it's very important to make a distinction between the people on the ground, who I think are doing a really good job. You know, they're doing an outstanding job, the doctors, the nurses, the allied health professionals, even the people who are running the A&Es. Because the A&Es in Singapore, they have fever facilities, they have the regular, they have the trauma areas. So they are quite well segregated. And as far as I know, there's been no transmission documented in the last 2 years, you know, in any A&E in Singapore. We've had transmissions in some of the wards, we've had lots of transmissions in nursing homes, but so far so good for A&E. Now, the thing that we're not happy about is the policymakers on top. And you know, I think this is part of the whole structure of the way society in Singapore is organized. A lot of stuff is top down, see? And some of the protocols and policies, while they look good in theory, you know, they've got all the fancy modeling and stuff like that, but when it comes to actually what's happening on the ground, there's a completely different story. So I think this is where, you know, we've put out this 8-point plan, and we've opened it for public consultation, and we're actually going to make the public comments public so that people can see them, so that we can debate, you know, these issues, and we can listen to the voices of patients, we can listen to the voices of nurses, of doctors, of people involved in trying to get this pandemic. And you know, settling the pandemic is not the 4G's job. It's the job of every Singaporean.
Yes, of course. So I think he has got another question. What is your understanding of endemic? And is endemic applicable to COVID-19 virus, as it is highly contagious and deadly?
Yeah, you know, I think that this word endemic is very misunderstood. See, it's not us who decide if the virus is endemic. The virus decides if it's endemic. See, an endemic virus is all over the world. I'll give you an example. What are the endemic viruses in Singapore? I just did a class for a master's student yesterday. And we did 4 endemic diseases in Singapore. We did hand, foot, and mouth disease. Okay, and they pointed out last year there were 30,000 cases of hand, foot, and mouth disease. Nobody knew, right? I mean, I was quite surprised to see that number. Tuberculosis, which is not a virus, it's a mycobacterium, but there were like 2,000 over cases if you counted both Singaporeans and non-residents. Dengue, of which, you know, last year was a record year. We had 20 over 1,000 cases of dengue, and of course COVID. But we had more deaths from dengue last year than we had from COVID. So dengue can be a deadly disease, but it's still endemic. You know, and we don't shut down, you know, schools and places like that for dengue. We do shut down work sites though. You know, if there's a construction site and they've had a certain number of cases, NEA can go in and shut them down. So that's a powerful incentive to the construction site to make sure that they don't become a dengue breeding cluster. Neither do we test asymptomatic people for dengue, even though we know that actually most dengue is asymptomatic. But what we do is we monitor individuals, we make sure that we have protocols that we can treat people with dengue, we recognize them, we train the GPs, in fact NEA provides free testing for the GPs so that they get kits so they can test the patients with dengue. And our dengue control has been relatively good. I mean, we have bad years, we have good years, but that's what potentially deadly endemic disease is like. See? And I think that's what we have to do with COVID. You know, not go paranoid, but at the same time make sure that people are well looked after, that those who need to get treated, and in fact dengue has been a switch. You know, 10 years ago the majority of patients with dengue were hospitalized, and we found that was putting a huge burden on the hospitals when there was a dengue outbreak. So what happened was every hospital now has a dengue outpatient clinic. So they monitor the patients, they come back every day, they get their blood counts tested, they get their blood pressure checked, and if they need to get admitted, they get admitted. If not, they're just monitored at home. And I think that's the way we need to start dealing with COVID. Recognize that it's a potentially deadly disease, But at the same time, we don't want to strain the healthcare system, and we want to try and let people live their lives as normal as possible.
Okay. So Ruth Chan also mentioned that she has the opinion that the MTF has been a huge disappointment, and she asked, what is your assessment on how the MTF has performed thus far? And because the impression that she is getting is that they are flip-flopping, with the response.
Yeah, frankly, at the end of June, when they wrote this editorial, Living with the Virus, I was very optimistic, because I thought that this is actually the future. See, that is futile to try and go to a zero COVID strategy. But somehow they are not convinced. See, it seems like they wanted to do it, but they didn't have the guts or whatever it is to push it all the way through. And to be fair to them, I actually blame Hong Kong. I got an interview with Hong Kong radio, and I told them, it's after that editorial, then Hong Kong turned around and said, okay, no more travel bubble, and that must have affected them to a certain extent. But I think, like I said, Singaporeans sometimes complain a lot, but this is why we felt that in the SDP we had to come out with this 8-point plan. So it's not just criticizing them for being flip-flopping and coming up with these crazy rules: 2%, 5%, 8%, then 5%, then 2%. It's just so confusing for most people, and it's affecting F&B operators. So we felt that we needed to have a sensible plan that actually showed a way out. And it was something that concentrated on the most vulnerable, because what we want to do is we want to prevent death and we want to prevent severe disease. We're not so obsessed with the numbers. We look at the numbers because they give us some idea of what's going to happen in the ICU moving forward. But I think we really need to relook at the approach, and I think a ground-up approach is far, far better than a top-down one.
So she also mentioned that now they have removed the report for unlinked cases, number of unvaccinated people in serious condition. Do you think this is a good idea?
Well, the linked and unlinked, you can actually find it in the appendix, because what they do is they will tell you how many are household clusters and how many are non-household clusters, and then you find that total is actually the linked cases. And then you subtract the total number from the linked cases. One of the reporters asked me about that, and then I realized, yeah, actually you can work it out, even though it's not explicitly stated like before. So they're not really trying to hide it. They just make you do a little bit of work to find out the figure. Among the serious cases, the vaccinated and unvaccinated, I think part of the reason why they're not doing it is because people are twisting it, and they're turning around and saying that, if the majority of the sick cases are vaccinated, then the vaccine doesn't work. But that is not accurate, because if 100% of the population is vaccinated and the vaccine is 95% effective, you're going to get 5% of the population being severe, and all of those will be vaccinated. You know what I mean?
Yeah.
So the reality is, I think, and to me, although taking away that information means you don't trust the people, or that your communication has failed. See?
Yeah.
So I think, granted, maybe they got a lot of things to think about, but they have some very expensive PR consultants, and they have very good communicators. So I think it's a matter of trying to communicate this to the public, trying to get them to look at this as a disease which can kill people, like dengue can, or tuberculosis, which kills older people in Singapore. But it's something that we can deal with, you see.
Okay. So now I think, is there any additional questions that we have? Okay. I think now maybe we can touch on a little bit of the SDP 8-point plan. Maybe Prof, you would like to share a little bit more on this?
So the first point is to stop testing asymptomatic vaccinated individuals. And I know a lot of people have started raising questions about this. We've seen this in some of the Facebook comments and the IG. And they're saying, what if these people can actually transmit the infection? And the fact is that there's been a study done by our local authorities, actually published in The Lancet, which shows that symptomatic people transmit far more efficiently than asymptomatic. And the asymptomatic in that study included pre-symptomatic. So pre-symptomatic means the day before the onset of symptoms. In reality, if you look at all the literature all over the world, the number of asymptomatic people who spread the virus or cause super spreading events is actually very, very small. So you want to focus on the symptomatic. And In fact, when they had the Tan Tock Seng outbreak, the group of doctors in Tan Tock Seng published a study in the Infection Control Journal where they showed that the routine testing of healthcare workers didn't help. It created false positives, it forced people to be quarantined. So the bottom line is that, and then as I was thinking about this, I asked myself, you see, which infectious disease do we do testing of asymptomatic people? We don't do that for flu, we don't do that for dengue, but we do that for tuberculosis. And who do we test in tuberculosis? We test the high-risk groups. We test the migrant workers coming in because they come from countries with high risk. So I think I'll modify that. The whole point about this thing is it's for public consultation. So that is a good point. So we will probably do asymptomatic testing for travelers because we can't be sure about their vaccination certificate. They have fake vaccination certificates which get sold overseas. So maybe certain high-risk groups. And the other people we test for TB are those who are going to get transplants or chemotherapy. So they have weakened immune system. So we may need to do asymptomatic testing for certain vulnerable individuals.
Okay.
So that's the first point. Sorry, a bit long story. so that's because that's the most controversial. See, this whole idea of testing asymptomatic individuals. The second point is that the decision to hospitalize people must be a medical decision based on their clinical conditions, and we need to use the PHPCs. The PHPCs have been tremendous. Several of my friends are GPs who run PHPC clinics, SASH, and there's so many acronyms, it's very hard to keep track of them. But basically, they have diagnosed people with COVID, they have managed to safely transfer them, and now we're at the stage where COVID is so widespread in the community that potentially they can send them back home and they can monitor them. It's so much easier to be monitored by the GP downstairs, rather than try and do a teleconsult with somebody from somewhere else, or to try and find your way to A&E and you end up waiting and actually taking up delaying somebody who really needs to be seen. So that's the second point, is the decision to hospitalize must be made on medical decisions and not just based on some protocol or other. So GPs should be actively involved in this process, and I don't see why not. And they should be compensated for it. The third point is nursing homes. Now, the nursing homes unfortunately have been affected by this virus, and it's been very difficult because they send patients over, and very often they don't have the resources to isolate or segregate the patients. But that is a lesson that because we have well individuals from nursing homes and they can't go to the community care facilities because many of them have dementia or they have nursing needs which are too great. They can't stay in the room with somebody else like this poor guy did. So we really need to have dedicated nursing facilities. They've started that in the one in Tampines. But ideally, the nursing home should be able to keep their own patients. And then they should be able to segregate them into clean areas and infected areas, and then just to look after them there. The fourth point is a dedicated ambulance service. Now, this is a recurrent theme that's come out on social media, on comments from individuals. They've tried to call the hotline, and frankly, the poor guys manning the hotline, they're swamped. You see, they cannot answer the calls. No one picks up the phone. They hear music. And so if we have a dedicated ambulance service that specifically picks up people who have low oxygen concentration, everybody now has a pulse oximeter. It's super easy to use. You put it on your finger. Once it drops below 95, you pick up the phone, call. See? And you can actually show it to the ambulance staff, and they can verify. They can tell you you didn't put it on properly, or something like that. Then they can send somebody to pick you up. And that's how you prevent mortality and death, by identifying those who really need care. See, rather than picking up people who are asymptomatic, test positive, put them in hospital. The other, number 5 was on reporting. And reporting, I suggested that, you put these numbers out here, it frightens people. So, 3,000, 5,000. What you need to do is you need to report test positivity, which is what proportion of people who are tested are positive. WHO actually has a threshold, 5%. We are way below 5%. See? And I think as long as that number stays low, then, it's not sugarcoating it, but it's actually giving you an accurate understanding of what's going on. Number 6 is no blanket bans. See, it doesn't make sense, when all this 2-person, 5-person thing, and then you can get up to 1,000 people at a religious event, or you can get 50 people at a wedding, and so it's just super confusing to people. What makes more sense is if there is transmission at a particular place because they're not following proper hygienic or safe distancing measures, then you shut them down. You know, we used to do that with childcare. We still do that with restaurants. If there's a food poisoning outbreak in the restaurant, you don't ban all the restaurants, right? You just close down that particular restaurant. See, we did that, you know, when they had the cholera in the Indian rojak stall. See, and the guy got prosecuted.
Yes.
So this is a mechanism which has been in place for many years, and there's no reason why we can't.
Well.
It works well, exactly. You know, people, it's pretty safe to eat. You know, it's safer to eat hawker food in Singapore than anywhere else in the world, probably. Number 7 was this genetic fingerprinting, and to spread it out, to make sure that right now Singapore has the ability, we have enough specialists, or if we don't, we should train them, you know, to be able to do the genetic fingerprinting in every hospital or every lab that does PCR testing. And once you've done that and you have a national database that is shared, that everybody can have access to, then that makes contact tracing a lot easier because you can link them up. We've started doing this for TB, and it's been tremendously effective. Some of you may have missed the story, but you know, for many years we've known that Bedok has been a hotspot for TB. And when I give a lecture, I say, oh, maybe it's because Bedok has a lot of old people. And that's what I used to think. Then actually I looked at the map, and actually Bedok does not have the oldest people in Singapore. It's in Radin Mas, Bukit Merah, where you've got more older people. And then finally the results came out from the genetic testing of the TB in Singapore. They realized that there was actually a Singapore Pools outlet in Bedok, which is where these uncles started spreading TB to each other. And so they were able to move in to do contact tracing, to screen these individuals, to test them, and hopefully they have stopped the Singapore Pools Bedok TB outbreak. So I think that's something that could be done. Like I said, we have the ability and the talent and the resources. And finally, you know, there's a lot of stuff on social media about comparing the different vaccines, about Ivermectin, about stuff like that. The way to answer that is to do a properly designed clinical trial. And it can be done. See, we did the trial in the dorm under really, really difficult circumstances. My colleague, Raymond Seat, he's a neurologist who wants to be an infectious disease doctor, but he's a tremendous team that he put together. You know, we consented more than 3,000 of these workers. We had people speaking to them in Bengali. We had videos that explained the study to them. And we got results which are credible. So that same thing could be done with Ivermectin. It could be done with Sinovac, Sinopharm, with AstraZeneca, with different combinations of the vaccine. And when you get results, see, then you can base your decision on evidence and a well-designed study rather than just anecdote or some guy's opinion on some video or other.
Yeah. So this 8-point plan came out by the SDP, is formulated by a group of doctors with medical.
Yeah, so basically, I mean, I drafted the sort of skeleton, and I ran it by people who were formerly in our healthcare panel, together with some of the volunteers, some of our supporters. Unfortunately, all of them are too chicken to be named, so that's the reality of opposition politics in Singapore. But I'd say a thank you to all of them. You know who you are. There were a couple of other points which we didn't have sort of space to include.
But the point is that this plan is drafted by medically trained doctors.
Correct. It's not drafted by Dr. Chi or the politicians. I mean, I did show it to him, and you know, he just said, "We'll leave it to you." And it was a mix. There was GPs, there were specialists, there were people in the public health field as well, and Ang Yong Guan, the psychiatrist and good friend, he wanted us to put in more on mental health, but you know, unfortunately, there's no space for that in this version. But maybe in the next time round.
Okay, so I think that's all the questions and points we have to share today. Before we close, I would like to ask the Prof to maybe you can share a message for those who are able to but still reluctant to take the vaccination.
Yeah, so basically the vaccine is extremely safe. My mom is 84 years old. She gets severe allergies to cockles, her face swells up. So we were very reluctant too. Then when they said, okay, it was safe, I waited until a couple of weeks when we had already seen some of our patients getting it. And she's already had 2 doses of vaccine and she's done fine. All of her friends have had the vaccine, and I think, like I said, there is not to downplay the fact that there are no side effects. There are side effects. And when you vaccinate 7 million people, you're going to get a significant number with side effects. Like I said, if it's 1 in 100,000, you've got 70 people with quite severe side effects which are going to occur. And it's unfortunate, and I feel bad for these 70 people, but that doesn't take away from the 6,900,000 who have not had side effects. And I think, with every viral disease, it's been vaccines which have kept it under control. I wish we had better vaccines. I wish we had vaccines with fewer side effects, but unfortunately that's what we have right now. The good news is the companies are all working on version 2.0 of the vaccine. Even Pfizer and Moderna, they are coming up with different versions of the vaccine. So hopefully we'll have better and safer vaccines. But right now, we take what we've got.
Okay. Thank you so much, ladies and gentlemen. We are done for the day, and if you have any further questions, please do drop in the comment. We will monitor them and perhaps add them into the next episode of APA. So that's all for today. Good night.
Good night.